on optimizing pharmacotherapy for tonsillitis. Optimizing pharmacotherapy for tonsillitis, a pharmacist review. And then this presentation is going to be made by no other person or pharmacist, Dr. Obi Onyedika E. from D, whose interest is in oncology pharmacy, has had publication to his credit and currently working on a number of studies, who is proficient in data analysis and a social media enthusiast. I remain yours, pharmacist Ahmed Gabriel Matthias Enoch, a fellow of the college, a member of CPAN, who will be moderating tonight. Please, if you are not given the opportunity to speak, can you put off your mic so that we can hear ourselves and push in this study? Sorry, I would have on my own video so that I will be live with my presenter. But I think in the next 5-10 minutes, I'm going to drive out of where I am as soon as the presentation starts to get a calm place so that this can be done. Thank you very much. On this note, I want to invite pharmacist Obi to hit the floor running with his presentation. Thank you very much.
Thank you very much, sir. Thank you very much, sir.
You're welcome.
I'm honored to be the presenter for this night, and I welcome everybody. Good evening, everybody. I am pharmacist Obi Emmanuel, so a pharmacist at Federal Medical Center, Owo, Ondo State. So I'll be presenting on a topic that states optimizing pharmacotherapy for tonsillitis, a pharmacist insights. Now, so the outline for this presentation goes like, as you can see on the screen: introduction, the prevalence, the causes, the types, the symptoms, the diagnosis, the treatment, the complication, the prevention, and then we have the case study. Now, for the first slide, that is the introduction. So it says, what is tonsillitis? So from the word tonsillitis, we cannot have a condition as tonsillitis without talking about the root word, which is tonsils. Please, before we proceed, I would like to talk about a little bit about tonsils. So what are tonsils? Now, tonsils are actually like, they are two small fleshy masses that are usually located at the back of the throat on either side. And usually these tonsils, they act as a first line of defense against pathogens like bacteria and viruses. That is, they prevent viruses and bacteria from entering the body, either through the nose or the mouth. And they are said to contain immune cells like the T cells, the B cells, and even the macrophages. So what they do basically is that they identify all of these infection, and also they help to neutralize it. Now, how do tonsils look like? So in a healthy tonsil they are typically pink in color and relatively small. However, when they become inflamed and enlarged, then condition known as tonsillitis come into place. Now, going on to the prevalence. So the incidence of tonsillitis is notably high, with millions of cases reported globally each year, according to the statistics, and usually it occurs predominantly in children that age between 2 and 15. And now you would want to ask the question why we have this condition occurring in young ones the most. First, you would agree with me that young persons are usually liable to picking up substances from the floor, hence exposing them to lots of bacteria, and also their immune system is not so developed. So all of this would make them quite susceptible to such conditions. Now, what are the various causes of tonsillitis? Now, usually tonsillitis has a viral origin and a bacterial origin. Now, different viruses have been known to be responsible for tonsillitis. And according to this slide, you can see we have the adenoviruses, we have the Epstein virus, we have rhinovirus, cytomegalovirus. And now going on to the bacteria, one of the most common bacteria that has been known to be responsible for tonsillitis is Streptococcus pyogenes, which is also known as A. streptococcus. But the other strains of bacteria are also responsible, but this is like the most common ones. Now, the type going on to the type of tonsillitis, we have acute tonsillitis, we have recurrent tonsillitis, and we have the chronic tonsillitis. Now, from the name, from the word acute, it means acute tonsillitis is usually the most common type of tonsillitis and refers to a sudden onset or onset of infection of the tonsils. And usually the person comes down with symptoms like severe sore throat, fever, swollen and red tonsils, difficulty or pain in swallowing. And usually symptoms usually last for about 3 to 7 days, but can persist up to 1 to 2 weeks. Now, for the recurrent tonsillitis, this refers to a multiple episode of acute tonsillitis occurring frequently over a period of time. It is not a persistent infection though, but it is actually a repeated kind of form of infection. So the diagnosis, before you can say tonsillitis is recurrent, we have a diagnosis criteria, and which one of it is at least 7 episodes in the preceding year, then at least 5 episodes per year in the past 2 years, and at least 3 episodes per year in the past 3 years. Now, moving on to the chronic type of tonsillitis. Now, for the chronic, this is actually a persistent infection or inflammation of the tonsils that lasts for a prolonged period of time, typically longer than 2 weeks, or reoccurs frequently in a continuous manner. Now, I would like to state this. For the recurrent tonsillitis, some research has actually suggested that a genetic component or an abnormal immune response in individual makes them prone to recurrent infection. Now, moving on to the symptoms of tonsillitis, we have myriads of symptoms that one would observe when it comes down with this condition. One of them is sore throat. Now, for the sore throat, the person is usually having difficulty in swallowing. So swallowing becomes quite difficult for this individual. Also, there is usually swollen and red. The person begins to have a swollen and red tonsil. So if the tonsil is usually pink, but when it starts deviating from the usual pink color and starts appearing to be red, then you could suspect tonsillitis. Then there's usually white or yellow patches on the tonsils. Then there's the lymph nodes in the neck becomes enlarged and quite tender. Then there's halitosis. Now, this halitosis is usually as a result of what we call tonsil stones and bacterial infection within the tonsils. Now, these stones are usually made up of bacteria and dead cells in the small cervices of the tonsils, hence producing a foul odor. Additionally, the inflammation can also be as a result of pus accumulation around this area. Then there is also coughing, body weakness. The person becomes very weak. Then there's also drooling. And this drooling is as a result of accumulation of saliva in the mouth, which the person then expels as drool. But in some cases, drooling can also be a sign of complications that we refer to as peritonsilla abscesses, that is the accumulation of pus around the tonsils. Then there is an unusual irritability, usually among young ones, and the temperature becomes very high. Now, it is very important for us to note that these symptoms can last for 3 to 4 days and can even continue to 2 weeks after the onset of the infection. Now, moving on to the diagnosis. Now, the diagnosis can be in two forms. We can have physical examination and we can also have laboratory tests. Now, for the physical
Hello,
examination,
Dr. Obi. Dr. Obi.
yes, sir.
Sorry, I don't know whether it's volume from my side. If it's from my side, then that's okay. Can you increase your volume a little? I don't know whether it's from me. If the other pharmacists across the nation are not having issues, I think you can just flow. But if it's the same thing, then you can increase your volume a little. Thank you.
All right, sir. So I said
But
for the
yeah, continue,
diagnosis.
continue. Yeah,
Okay,
now I can hear you better.
okay. I said for the diagnosis is I divided into two parts: the physical examination and the laboratory test. Now, for the physical examination, basically what is being done is that the throat is being examined for maybe there's redness, or maybe it is swollen, or maybe there are patches around the tonsils. Now, for the laboratory test, we have different types. We have the throat swabs, we have the rapid antigen detection test, we have the throat culture, we have the complete blood count, and we also have what we call clinical scoring skills using tools like Center Score. Now, for that particular one, I would like to emphasize on that particular one, that is the clinical scoring skill using tools like Center Score. So how this works is that usually is based on four criteria, and now this criteria includes maybe there is a tonsillar exudate, or maybe there is swelling, or maybe there's an enlargement of the lymph node, or maybe there's a presence or absence of cough, or maybe there is fever or absence of fever. Now, this score is usually ranging from 0 to 4. And so when we have score ranging from 0 to 1, it suggests that there's a probability of strep throat, and further testing might be needed as well. And when we have moderate risk score, like that is 2, a score suggests a moderate probability, and further testing is also needed. But when the score is now 3 to 4, a high score indicates high probability of strep throat, and further testing is also required. Now, moving on to the treatments. Now, for the viral origin, for those ones that occur as a result of viruses, now there's no specific medication for viral tonsillitis, rather it resolves on its own. And usually, how do you manage these ones? You can advise the person to rest, or to take enough water, that is remaining hydrated, or the person could also indulge in warm salt water gargle. The person could also use humidifiers. Now, for the bacterial origin, usually we will make use of antibiotics. Penicillin is usually the most prescribed for group A streptococcus, usually taken for 10 days. So in situation whereby we can't make use of this, then there are other alternatives like the macrolide, the azithromycin, can also come into place. Now, it's also advisable for us to advise patients like this that they should make sure to continue medication even after they are being relieved, because to avoid situation like antibiotic resistance. Now, the person can also be isolated. Reason being that tonsillitis in itself is not transmissible, it cannot be transmitted, but the organism, the positive organism, the bacteria, usually transferred via airborne, that is as a result of coughing or sneezing, either ways. Now, for the surgery, that is the tonsillectomy, that's to do with surgical removal of the tonsils, usually recommended for recurrent or chronic tonsillitis. When I was explaining, I made mention of recurrent tonsillitis and also chronic tonsillitis. So when one is experiencing recurring tonsillitis over and over times, then we could go for surgery, that is the tonsillectomy, especially if it has a significant impact on the quality of life, or causes complications like the obstructive sleep apnea, the breathing difficulty, and also difficulty in swelling, as the case may be. Now, what are the different complications of tonsillitis? The first one there is the peritonsillar abscess. Now, we have the obstructive sleep apnea, we have spread of infection. So this untreated tonsillitis could also lead to spread of infection. There is, we also have sinus infection. Then we also have rheumatic fever. We have post-streptococci glomerulonephritis, that is the inflammation of the kidney, that if not treated. Then we also have scarlet fever. And this scarlet fever, the tongue and the skin appears red. So all of this can result if the tonsillitis is not being managed over time. Then I had already talked about tonsil stones, that is the accumulation of debris around the tonsils and leading to foul smell. Then there could also be pediatric autoimmune neuropsychiatric disorder as the last one there. Now, moving on to the next slide, which is the prevention. Now, in order to prevent this condition called tonsillitis, it's advisable for us to always practice regular hand wash. You should always make sure you wash your hand regularly. Also, staying hydrated at all time, then boosting one's immune system with mineral, vitamin, as well as indulging in regular exercise. Then avoid irritants and also good oral hygiene, which includes proper brushing, flossing, and using antiseptic mouthwash. Now, moving on to the case presentation. So, the demographic of this patient. So patient AB is an 18-month-old male child weighing 8.5 kg, a native of Owo, Ondo State. Now, the chief complaints: general body weakness, fever, reduced appetite, cracked voice, and hypersalivation. Now, history of illness. The patient was brought to the hospital by his mother. He had fever for 3 days with a temperature of 38.9 degrees Celsius on admission. The fever relieved with paracetamol syrup for 2 days before the re-emergence of symptoms. The tonsils were covered with white plaques and it was observed that they were inflamed. Now, the social history. Patient is the second child of a monogamous family. His father is a businessman and his mother is a housewife. The patient had a history of putting foreign substances in his mouth. Now, for the past medication history, antipyretics for 2 days given by the mother for high body temperature and cyproheptadine to stimulate appetite. Now, moving on to diagnosis, from clerking the mother, clinical examination, and also laboratory investigation, the patient was diagnosed with acute tonsillitis, malaria, and moderate dehydration. Now, the treatment plan for this patient. So, 4.3% dextrose saline, 500 ml over 24 hours. Then we have IV paracetamol, 125 milligram when necessary. We have IV ceftriaxone, 850 milligram daily for 3 days. And we also have IV metronidazole, 65 milligram 8 hourly for 3 days. And IV artesunate, 26 milligram for 0, 12, and 24 hours for two days. Now, upon discharge, this baby was given syrup, that is vitamin C, 200 milligram 8 hourly, then suspension cefepozotide 45 milligram 12 hourly for 5 days, then suspension metronidazole 85 milligram 8 hourly for 5 days, and also suspension amoxicillin 110 milligram 8 hourly for 5 days. Now, evaluating the therapy of this particular patient. So for the 4.3% dextrose saline 500 milligram, it's quite appropriate because the baby was dehydrated upon admission. Then for the IV paracetamol 125 milligram when needed, this is because the baby was experiencing fever. Then the ceftriaxone 850 milligram daily for 3 days was also appropriate. Why? Because now ceftriaxone, the baby was diagnosed of having acute tonsillitis. And now the metronidazole 65 milligram 8 hourly for 3 days was also appropriate because metronidazole usually would affect or would attack anaerobic organisms. And so there's a synergistic effect in terms of the metronidazole and the ceftriaxone, hence why it was combined. Then for the IV artesunate 26 milligram, this was because the baby had symptoms or was diagnosed of malaria. Now, upon discharge, the baby was given vitamin C 200 milligrams. This was basically to boost the baby's immune system. Then the cefepozotide was given because if you look at this therapy, it's actually a step-down therapy. So we have started with a third-generation cephalosporin. Hence, the reason why we also continued with cefepozotide, which is also a third-generation class of cephalosporin. Then we have metronidazole suspension, synergistic effect, then the amoxicillin suspension as well. Now, going on to the drug therapy problem. So the actual drug therapy problem here, it was unnecessary drug therapy. Now, I made mention of amoxicillin is a class of penicillin beta-lactam, and so is cefepozotide, which is a third generation cephalosporin beta-lactam, and both equally effective against respiratory tract infection, thus amoxicillin was quite unnecessary. Now, the intervention, the patient was contacted and the prescription was adjusted with the withdrawal of amoxicillin suspension. And you would agree with me that usually cephalopodoxime has a broader spectrum of action than amoxicillin. And so there was no need combining the two, both of them, since they have the same function. Now, other drug therapy problem was untreated indication. So no anti-inflammatory medication was prescribed. Hence, the physician was also contacted and it was adjusted with the addition of an anti-inflammatory um, medicine, that is the syrup ibuprofen, 100 milligram 8 hourly for 3 days. Now, basically, the goal of therapy was to actually alleviate symptoms, that is, to reduce fever, to stop the general body weakness, and also to rehydrate the patient. Also, one of the goals was also to resolve tonsillitis. This means addressing the inflammation and also trying to make sure that the white plaques on the tonsils were um, were haunted, hence improving appetite. Also, enhancing the overall well-being of these patients. This is that is boosting the body immune system, hence why we gave the vitamin C. Also, preventing complications. So, like I said before, if acute tonsillitis are not being treated over time, it could actually lead to different types of complications. So we wouldn't want that to occur in this patient. So one of the goal of therapy was also to prevent complications that might arise as a result of this condition. Also, educating caregiver. Now, this patient was educated to try as much as possible to maintain a proper hygiene since the patient was a baby. And I made mention of the fact that baby are usually liable to picking up substances from the floor, which could actually pose them to such condition as tonsillitis. So the mother was advised to make sure that a proper hygiene was maintained in their home. Also, the mother was also advised to also provide guidance on home care practices and also recognizing signs of worsening symptoms. Now, going on to the pharmaceutical care plan. So the medical condition as there is tonsillitis, the drug therapy problem, unnecessary drug therapy and untreated condition indication. Then the goal of therapy as stated above, pharmacist intervention, that is the medication management. The prescriber was contacted with a corresponding withdrawal of the amoxicillin suspension and the addition of ibuprofen. Then the mother was educated on the nature of tonsillitis and the importance of giving patient AB the complete medication, basically to prevent drug resistance and also to boost the immune system and also achieve an effective outcome. Now, the mother was also counseled on how to prepare the powdered medication and administer it properly, which includes storing it in the refrigerator. And also, I think I didn't mention it in the slide. The mother was also advised to stop the use of the cyproheptadine because usually cyproheptadine is an antihistamine drug, so it's not for someone to use it to keep boosting appetite because it has its own side effects. So the mother was advised to stop giving the baby the cyproheptadine. Now, going on to the outcome. Now, the outcome was divided into clinical outcome, humanistic outcome, and economic outcome. Now, for the clinical outcome, the chief complaint was resolved, and there was improved rehydration and electrolyte balance was maintained. The acute tonsillitis was effectively treated. Now, going on to the humanistic outcome, the patient's caregiver was satisfied with the healthcare provided. And for the economic outcome, the patient was able to afford all of the prescribed medication that was given to them. Now, moving on to the follow-up, the patient's caregiver was advised to bring the patient after 2 weeks for evaluation. And the whole process, the pharmaceutical process that was carried out on this patient was properly documented and kept in the pharmacy. Thank you very much for listening. Thank you all for listening.
Hello. Thank you, Dr. Obi, for that wonderful presentation.
Thank you
I
very
think
much. Thank you. I am here. I am here. Someone muted me. Hello, ma.
yeah, continue.
Okay. I don't know who muted me. I'm supposed to mute myself, but someone muted me. All right. Thank you very much, Dr. Obi, for your presentation. And that was a wonderful presentation on tonsillitis. I've had two children with tonsillitis. The first was operated, and the second one is billed for operation. So it's a topic I'm well interested in, although it's not just tonsillitis, but adenotonsillitis. So I'm also interested in this topic. Dr. Obi, thank you again. We are going to have time for questions and answers. And I think he was clinical in his presentation, not too many theories. There was a case study there as a pharmaceutical care expert specializing in clinicals, not the too many of the history and all of that, these cases that are practical. So it was a good presentation for me, very brief, concise, and short. Please, the floor is open for questions. Whatever state you are in Nigeria, wherever you are, our elders, our professors, our consultant pharmacists, Dr. Obi is here before you guys and all of us. So let's ask our questions and then let him do justice to them. And also, if you want to contribute, I feel indicating by the raise of hand will be most appropriate. Thank you very much. Hello, are we all here?
Yeah, Famame, there are people raising hands, and you can see them, Kingsley, Sibo, and then Matthew. Can check
Please,
your
something
reaction.
is happening. Yes, I'm trying to check out my reaction, but something is happening. Please, for the meantime, those raising up, I'm actually using a new phone. So I'm trying to check the raising of the hand and it's giving me an issue. Please proceed. With anyone raising their hands, can you proceed while I just check what I'm checking? Let them continue to ask their questions one after the other. Then the presenter can do justice to them. We can take 3 questions at once or 2.
Hello, everyone. Good evening, Saz and Maz. Can you hear me, please?
Yes,
sir.
we can hear you.
Thank you very much, Pharmacist Obi, for your very insightful presentation on tonsillitis. My question is very straightforward.
Please, may we
Beginning,
know you, sir?
my name is Pharmacist Kingsley from Delta State. Apologies, I
Okay.
should have started with that. So there was a question that popped up in my mind when I was going through your slide. So you made mention of viral tonsillitis and bacterial tonsillitis. My question is, how can you differentiate both of them clinically?
Okay. Thank you very much for that question. Okay, like I said for viral tonsillitis, first off, for viral tonsillitis, we don't resolve viral tonsillitis with medication. What we do is supportive treatment, and I made mention of some of the things that one could do if the person has been diagnosed of viral tonsillitis. So the differentiating factor would be the result that has been gotten from the laboratory test that the person has done in the hospital, either ways. So for the viral tonsillitis, it resolves on its own, that you don't have to make use of medication before you are able to resolve it. Unlike the bacterial tonsillitis that you have to make use of medication to get it resolved. I don't know if you understand. I don't know if you get what. I just said. And if you're
Okay,
not
let me rephrase the question. In the absence of immediate laboratory investigations, is there a clinical way to differentiate and to examine the patient and say, oh, this is viral, oh, this is bacterial, while we are
okay,
waiting for culture results?
okay. For now, I feel like you have to go through the test. That is for some specific tests that I mentioned, like the complete blood count and the throat culture. It would actually like differentiate. Well, let me see, these tests are the ones that will give us a diagnosis whether it is caused by bacteria or whether it's caused by a virus. So until the test result is out from either the throat culture or the complete blood count, one might not be able to differentiate whether it is as a result of virus or bacteria.
May I say something on this? Hello?
Ed, who is speaking?
Go ahead. Go ahead.
May I
Dr.
say
We can hear
something?
you. Please,
Okay, this is
one
Dr.
after
Faith
the other. Who
Iriferi.
is talking?
I think, okay, Dr. Faith Iriferi from
Okay,
Delta
go ahead, ma.
State.
Go ahead, ma.
Okay, so I just wanted to follow up with what I think From Kingsley just asked, From Kingsley from Delta State too. So listening to the presenter, I was expecting he was going to throw more light on this viral causes and bacterial cause of tonsillitis. I think I'm not saying I'm going to give the full answer to that question, quite all right, but I know one of the differentiating factor is in this white patch presentation. So for bacterial causes, you have usually that white patch presentation. So when the doctors usually in their offices, they use the tongue depressor and then they check it. Just the presence of a white patch tells a bit more that this might just be a bacterial cause or bacterial origin, and before the test results, return. And then also, even in the kind of fever too, yeah, low grade fever most times for viral causes compared to that of bacterial causes. So I know those are two differentiating factors for, this before you start talking about getting the test results and then knowing whether this indication is high or that is high. So I just felt like chipping in this, these answers. Thank you. Contribution.
Thank you, pharmacist. Please, we have another third question. You have a question, can you ask so that I can sum it up?
Good
In the absence of any other, okay, go ahead, sir.
Good evening, everyone. My name is
Evening, sir.
my name is Pharmacist Ade. I'm using my phone, my colleague's phone. So I'm from Ondo State. Thank you, Mr. Presenter, for this wonderful presentation. My question is this: during the course of your presentation, as a pharmacist, one of your clinical interventions was removal of
Please, can
amoxicillin.
you mute? Let other people, if you're not speaking, mute. Continue.
Okay, one of your interventions, sir, as a pharmacist, was removal of amoxicillin there. So my question is, we all know that the amoxicillin that was removed was one of the first line treatment. Why did you prefer going for cefodoxime instead of amoxicillin, sir? Thank you. That's my question.
Okay. When I was explaining, thank you for that question. When I was explaining, I made mention of step down therapy. So when we started the treatment upon admission, we made use of ceftriaxone. And so upon discharge, ceftriaxone and cefodoxime, they belong to the third generation cephalosporin. Now, and it's also quite understandable. I believe we all know that cephalosporin is also it has a wider range for disinfection that amoxicillin, is why we removed the amoxicillin since they belong to the same class. I don't know if you understand.
Thank
Yeah,
you,
that's
sir. I understand.
pharmacist Toby. If it's,
Yes.
I don't know whether they are satisfied with your answer, but there are other two questions for you to put together and answer.
Okay, sir.
So just flow. Two other persons asked a question before now.
Okay, trying to.
Okay, or was it a contribution? The other person was the second person, I think, was a contribution. She was talking about diagnosis. That was a contribution.
Yes, it was a contribution, sir.
Okay. It's all right. I don't know. The answer you have given, if it's satisfied, fine. If it's not satisfied, can he give us any scientific or what he knows about the answer you have given? In the absence of that, if it's not asking any other question, more questions can they come in? I have a question to ask. All right, while we await other people to ask their question, I want to say...
There's a question here now. There's a hand up.
Dr. Obi, are you there?
Yes, sir.
Their moderator
Yes.
is raising hand.
No. Okay,
Yes.
okay, please. Anybody raising hand? Sorry, sorry, I'm using a new phone and the portion
He's
where I
raising
can
hands.
see hands. Okay, please, anybody raising hand, let's have them before I will ask my question. The person raising hand can go ahead.
Okay, good evening, gentlemen. We are all gentlemen anyway.
Thank you, sir.
It's an observation.
Please, can we know you, sir?
My name is Bola Olayiwola.
Okay.
I teach pharmacy at Achievers University. And somebody is talking and disturbing.
Just go ahead with your presentation. Go ahead with your question.
May I observe that since the 70s, when we trained, there have been a discouragement about use of drugs for issues like tonsillitis and other things that are self-limiting. I really don't know at what point we started bringing flagyl, IV flagyl, IV this, IV that. Because whether bacterial or viral, the only thing you are worried about is super infection. Once there's no super infection, some of these things are limiting. And for a child, till tomorrow, the resolving issue is treatment of malaria. Because malaria will come with about 9 symptoms. You know, incidentally, tonsillitis is one of the 9 symptoms. So, resolving malaria over time might have resolved most of the issues connected with this. That's why I'm worried that we have to bring a barrage of drugs, antibiotics, and all this. It's like, yes, we can, you know, I agree that you cannot leave a child, you know, to be in pain and this and that. But in any of such cases, first resolve malaria and see what happens. You know, that is my observation. Maybe things have changed since 1977. Thank you.
That's a good point.
All right, thank you for your question, or a contribution rather. Hello, any other question?
Yes, I have a question.
Please go ahead.
Okay, good evening, everybody. My name is
Good
Pharmacist
evening.
and I'm from
Pharmacist of
Akwa Ibom.
where? Akwa Ibom. Okay.
Thank you very much,
Okay.
Pharmacist, for the nice presentation. I had a little challenge recently. I want to know what causes frequency of tonsillitis in a child of about 3 to 4 years. The first 2 months interval. What could be the major cause? Thank you.
Okay. Thank you very much for that question. When I was explaining during the course of my presentation, I made mention of the fact that for young ones, their immune system are quite low, and usually they are usually liable to picking up objects from the floor, hence making them prone to such infection as tonsillitis.
Okay, I've heard you. Are you trying to say that it's only from picking objects from the floor that one can get tonsillitis frequently?
Actually, bacterial infection can actually set in from picking objects from the floor. And like I said, if the person is also with somebody that has this condition as tonsillitis, sharing utensils with this person can actually lead to the transmission of such condition.
Okay, thank you very much.
All right, now.
Thank you. Any other question? My education chair, you are the one assisting me plenty because of this hand raising. I cannot see that here, and I'm shocked.
Okay.
So if
I can't see any other hand. I can't see any other hand. So
okay,
for me, what I want to contribute, I don't have a question.
okay,
What I want to contribute is in the drug therapy problems that Dr. B identified. I'm looking at IV artesunate, at 0, 12, and 24 hours. I was looking at it. I was wondering because it's, I don't know whether it's enough. I don't know whether it's enough. I was expecting that that part of the medications that the patient will be discharged home, there should be an oral anti-malarial there. Because normally when you start IV artesunate, with time you stop, you switch over to oral when the person is now stable. So that's what I want to add, that I feel there should have been an oral anti-malarial for the child to go home with, though it depends on how many days anyway. Then in addition to what the lady added about the differences between viral and bacterial tonsillitis, that's why patch is quite significant. But also, you don't normally see, is it not running nose? It's not as much in bacterial tonsillitis. Viral has to do with that tearing and running nose, even cough. But more of that running nose is more in viral. It's another key difference. Just wanted to add that. Thank you.
thank you, ma. Thank you so much, Dr. Obi. We have many enlightened people on tonsillitis because of parenthood. So in the absence, is there any other question or contribution before I ask my own question?
Okay.
So let me just go ahead.
I said to help you, I'm not any other hand raised.
Okay. Dr. Obi, I don't know. Do you start managing tonsillitis as soon as you notice tonsillitis, or you wait until you carry out laboratory findings? Since you may not tell whether it is viral or bacterial. And on the other hand, a child is going through pain. Will you wait for the test result before you manage a child with tonsillitis, or you give what do we call this now? You give a general approach to it. You treat both as viral and as bacteria to put the child in a safe place. Or you are going to use your subjective or findings like every other person is contributing to say this is viral and therefore no need for antibiotics with your subjective findings alone, or you want to wait, combine your laboratory findings while the child is suffering before you treat. I want to get that clear.
Okay, all right, sir. For my own subject, what I would do if I'm in that position, you don't really have to wait for the test result to be out before you start treating such individual. I feel like first off, you focus on the symptom that is based on the symptoms that the person is showing or experiencing. So for the fever, you could give paracetamol. So you don't wait till the test result. So you just treat the symptomatic this thing, the symptoms that is quite visible that you can see. Then while you wait for the test result to be out.
Right, thank you. I'm saying that because of many community practices. Many community practices, if not for experts, like you're trying to say one or two, they go give, they treat for any tonsillitis that has brought fever and the rest. They give antibiotics. They give anti-inflammatory agents like ibuprofen or brustamin. And then, of course, stuffs like antihistamine to alleviate inflammation, improve airway, and all of that for the child. So for many community practice that I know as a pharmacist, that's what is done. I too have been in that shoe, even without laboratory findings. So I don't know where we're going to put it, particularly for community practice. So if you are not expert enough to know whether it is viral or bacterial, and then pharmacoeconomics of the patient is involved, additives, side effects, and all of that for a child that may not need even antibiotics. So I don't know what advice as a professor in management of tonsillitis that you can give to pharmacists practicing in the community. But I'm saying the norm that I know. So I don't know where we are going to place that. Most times, pharmacists in the community do not even send for laboratory findings. They just go ahead to manage a patient. Thank you. That's my question on that. So, achieve results. Are you with me? Are you listening? Hello, pharmacist Toby, Dr. Obi.
Yes, sir. Yes, sir.
So, at the end of the day, they achieve results, but the results may leave the patient with maybe toxic effects of or adverse effect of antibiotics if the child doesn't need it. On the other hand, the child takes the antibiotic, he needs it, but in most cases, the tonsillitis are resolved, except it's because there are tonsillitis that are resolved with surgical intervention. So in most cases, the community pharmacists achieve achieve the resolution of tonsillitis that is not requiring surgery. But there are pharmacoeconomics aspect to it, and there are other adverse effect aspect to it. So please, can you just give us a professional view on how it should be handled in the community outside of this general practice that people carry on? Thank you.
All right, sir. So like I said, can everyone hear me?
Yes, we can.
Okay. So like I said, I would advise that anytime we see or anybody comes to our for the community pharmacist to our maybe our premises presenting with tonsillitis, it's not for us to start bombarding them with different antibiotics. Like I said, first off is to make sure that we are able to tackle the symptoms that such person is presented with. That is the basic thing. Then after the whole test result is out, though for some tests like the culture test, it could take a while before it comes out. So while the test comes out, and based on the distinguishing features that the other pharmacist has stated, that is to know whether it's virus or caused by bacteria. Based on that, then we could know or we can actually attest to kind of treatment that we would prefer at that particular point in time.
Okay, thank you.
Yes.
It's all right. I may not have done the research, but I know that, which means what most community pharmacists are doing is out of order, going by your presentation. And that is given because most of tonsillitis, if I follow your presentation very well, let us say 50 to 70% or even 80% are viral in nature, not bacterial in nature. So, which means that we are spending the patient's money or the relative's money, I mean, in terms of community settings. Like I said, I'm yet to do the research. But what you have presented is not the practice that many of us can testify. But of course, research should back it up. Let's say for Benue now, if I go and do a research on the management of tonsillitis in all community pharmacy, almost all of them will be involving antibiotics, almost all. So if that's not the case, and the majority of tonsillitis is viral in nature, which means we are spending our pharmacoeconomics dynamics as it has to do with the patient, which means that we are spending the patient money unnecessarily. I'm saying this so that all of us can look at it as a topic of research, particularly in community pharmacy, where there's no multidisciplinary, is the pharmacist, is the physician, is everything, and then you spend the patient's money for something. If it's viral in nature, it's self-resolving. So that is costing, there's what we call economic cost on the part of the patient in most Nigerian community settings. That I know. But we can all go and do our research, management of tonsillitis in community pharmacy, and then we'll see whether more harm or good has been done to the patient, because it's a common phenomenon. Tonsillitis is very, very common. So that's my take. And then community pharmacists should also upgrade according to your presentation now. Let's see how we can help the patients. If people don't need to spend money, they don't have to spend money. But if you said, since you are not proficient enough, whether they spend money or not, once they become fine, that's okay. So for me, it's something that bothers me, and I think we should research more. I saw you take a case study. We can take it maybe hospital by hospital. If you can research in your hospital, but I'm not interested in a multidisciplinary setting. I'm interested in the community setting where you just give a general treatment, somebody becomes well, but maybe some unnecessary indications. You are giving some drugs, which is a drug therapy problem, that the patient does not need. In as much, the patient may even get well in the process, but he does not need the drug. That is economic cost on the part of the patient. Thank you. Please,
Thank
any
you.
other contribution as we try to shut down? Questions or contributions? In
No hand.
the okay, in the absence of that, I don't know. This phone is trying to fall my hand, but I think I will win at the end of the day. I'm looking at the participants here. We have about 30 at the point it was 38 participants. We're having like 30 now, and I cannot see our national CPAN chairperson, Dr. Maureen. I would have said she should come and
Yeah.
hello, ma. Is she there?
Yes.
Is
Good.
there?
Okay, yes. I've seen you, ma. Good evening, ma.
Good evening.
Thank you, ma. So the floor, I want you to make a comment and then a remark concerning the presentation, a question or a contribution for all of us that are members of CPAN across the country. You are welcome, ma.
Thank you so much. I'm glad that I joined later, a bit late. But I want to start by congratulating Ondo State CPAN for bridging the gap to make tonight's presentation possible. Thank you so much, Ondo State. I want to thank the presenter, Dr. Obi Onyedika. Thank you so much for a good work you did. And our dear moderator, Dr. Ame Gabriel. Thank you so much for moderating well. On the course of this call, I saw our dear Professor Bola Joko Aina. Prof, thank you so much for making our time to be with us. I also noticed Professor Val Odiri, the chairman of Faculty of Clinical Pharmacy, WAPCP. Thank you, Prof. You're always here with us. I want to also salute our dear CPAN Education Committee Chairman, Fami Fiemoma, for a wonderful work you've been doing since this mantle was given to you. Thank you so much for your dedication. Okay, so our number tonight wasn't all that good, but to try to talk to our members, try to share our advert so that more people will join us next time, maybe next week, Friday. Okay, concerning what we heard this evening, I'm still in line with the last speaker that spoke about what is happening in the community pharmacy in terms of managing tonsillitis. That is the basic truth. In the community pharmacy, once there's a child with tonsillitis, they will initiate antibiotics, anti-inflammatory, maybe anti-allergy or something like that. It has been the practice. So, and we are talking about the research. As clinical pharmacy, let us do this research and come up with the real right way to manage such disease in the community pharmacy. Because at that point in time, there's no test to do, nothing, we are just there alone. So I hope that we can look into this and come up with a good protocol for us to do that in the community setting. So on this note, I want to say thank you everyone for joining us tonight and have a wonderful good night rest. Thank you.
Thank you, our chairperson and mommy for this remark. In the absence of questions, contribution, as Clinical Pharmacists Association of Nigeria, we would like to draw the curtain for today's presentation as we await other presentations that will boost attendance, boost intellectual exchanges. I would like to welcome, I don't know, well, let me give another space to our education chairperson, our national education chairperson. Our national chairperson have spoken. Please, can we have your remark before I call someone for the closing prayer tonight?
Okay, I appreciate everyone for making our time to be in the meeting. And I thank you, our moderator, for even in spite of what you are going through, you're able to do something. And thank you so much, Dr. B. I spoke to you, I think within a week, you were able to come up with this. I'm actually impressed. God bless you. And thank you very much, our retired DPS in the house, because this is Ondo State. I'm from Ondo State, so this is my state. So our retired DPS is in the house, both of them, Dr. Oluwatimilehi and the pharmacist, Oluwatayo Motoimbo. And some of my bosses here, Dr. Fashua, Dr. Lowoshusi. I appreciate you. And I can even see one or two interns. God bless you for coming. And I want to encourage us to also make ourselves available for next Friday's lecture. So that is all. Thank you very much.
All right. Thank you, Ma. Thank you for your closing remark. We hope that we'll do better and better and better as the Education Committee to push CPAN forward and do great things nationally and even internationally. Thank you very much, Ma. At this junction, we had an opening prayer from a Christian. Can we have a Muslim close this prayer? I'm seeing pharmacists or Dr. or Professor Suleiman Olawale Abdulaziz. I don't know if you can lead us in a closing prayer, or any other Muslim in the house.
Good evening, everyone.
Good evening.
All adoration and glory belong to Almighty God for giving us another opportunity to witness today. We thank Him for all what He has done for us and the knowledge we have shared from today's webinar. May God continue to be with us.
Thank you. God bless you.
Amen.
God bless you. Amen. Everybody have a
Good
wonderful
night.
night rest.
Good night.
Across Nigeria, God bless
Good
every
night,
one of you.
everybody.
Good night. Happy weekend.
Same here to you. Bye.
Now, don't carry yourself complaint for platform to this. When you go look for people, you know, go save 3-4 people. Thank you. See.